Well, welcome back to the World Stroke Academy podcast series on the whole of factor 11, 11A inhibition and stroke prevention. In this, my name is Octavio Pontes. I am a neurologist. I'm a professor of neurology at Ribeirão Preto Medical School, University of São Paulo, Brazil, also the editor-in-chief of the World Stroke Academy. And in this episode, we're going to take a closer look into the methodology and the results of the OCEANIC trial, one of the most important and anticipated trials that has been published at presented at ISC and then recently published in New England Journal of Medicine. And I'm very pleased to have with me today Dr. Mike Sharma. Mike is a professor of neurology at McMaster University and a globally recognized leader in the field of stroke neurology and vascular trialist. He also has an important leadership role in the development of the applications and the strategy of factor 11, 11A inhibition for stroke prevention. Thank you very much, Mike, for joining us today.
Thank you for the invitation, Octavio. It's a pleasure to be with you.
Thank you so much. Mike, what are the key design features of the OCEANIC trial that clinicians should understand?
So, OCEANIC-Stroke was informed by a phase 2 trial, Pacific-Stroke, where we got a sense of the safety of this agent, asundexian, and as well an idea of the feasibility of doing a trial like this. So we have to remember, for the last 50 years, aspirin monotherapy has been an international standard. A minority of patients get dual antiplatelet therapy. So in the trial, when we were designing it, what we wanted to do was ensure that it was a feasible time point to start the medication and also that the medication could be continued for a long time. So patients were randomized within 72 hours of symptom onset. So unlike the dual antiplatelet trials, which were 24 hours of onset, we allowed 72 hours. This did two things. First, it's going to be easier to make the transition into clinical practice, and also it allowed for patients which were not included in the dual antiplatelet trials. So these are people who've had IV thrombolysis or mechanical thrombectomy. We asked people to wait at least 24 hours after those hyperacute therapies to randomize patients, but got them in. And after they were started, on top of standard therapy. So everyone in the trial was on antiplatelets, either single or dual antiplatelets. So asundexian or placebo was added, and then continued until we had enough endpoints, enough ischemic strokes to make a decision about the trial. So if you think about the randomization window, we were not terribly selective in the patient groups. It should be easy to translate.
That makes a lot of sense. Mike, could you summarize to us the most important results in terms of efficacy and safety of the trial?
Yeah, so the primary endpoint was the occurrence of ischemic stroke. Asundexian reduced the occurrence of ischemic stroke. The hazard ratio was 0.74, quite a significant accomplishment. We also saw fewer disabling and fatal strokes, so that hazard ratio was 0.69. So not only did it reduce strokes, but it reduced the worst type of strokes. And just recently at this meeting, we presented data to show that the strokes, when they occurred, were milder than on placebo, which is a very nice finding as well. Less likely to have a stroke, milder when it occurs, and better recovery. The very nice thing for us in these findings was a consistency of the effect across subgroups. So different ages, sex, geographies around the world, racial categories, risk factors, whether or not there was a history of atherosclerosis, whether or not it was visible on imaging, all of those subgroups we saw really equal efficacy in. So I think that also makes it easier to apply. Even unlike dual antiplatelets, you don't have to think carefully, what is the severity of the stroke, is there atherosclerosis, all of those things we think about with dual antiplatelet therapy. This, I think, will be easier to do. The other, I must say, very pleasing finding was we did not see an increase in hemorrhage. No increase in ISTH major hemorrhage, intracranial hemorrhage, hemorrhagic stroke. In fact, numerically, but not statistically significant, there were fewer hemorrhagic strokes with asundexian than with placebo. And the one, hemorrhagic outcome that we usually don't pay enough attention to is the occurrence of minor bleeding, which is very important to patients. We did interview patients designing the trial, and they told us this caused stress, anxiety, and frequently made them stop medication. So minor bleeding was not increased over placebo, which I thought was quite a remarkable finding.
Yes, Mike. So 26% reduction in ischemic strokes and no increase in bleeding is such a important result. What are, for our audience, the main strengths that we would highlight in the study?
I think that the big strengths are the broad population that we applied it in and the reasonable entry window of 72 hours to get it in. It was a large trial, so we were well powered to look at some of these secondary endpoints and some power in the subgroups as well. Had it been smaller, we would still have some unanswered questions. So I think that's the ease of applicability, the ease of translation of the clinical trial results into practice, I think, is a great strength of this design.
All right. Thank you so much, Mike. This was very helpful for us to understand the impact of this trial in stroke prevention. Thank you so much.
Thank you for the invitation. Pleasure to be with you.